Good afternoon, everyone, and welcome to the third and final panel of the Journal of Law and Society's Symposium about the opioid use disorder epidemic. Thank you for being here with us on Zoom on a Friday. Before we open the panel, I'd like to extend a thank you to all of the members of the journal for their work this year, including on our spring issue, which will feature our symposium articles. We encourage you to take a look for more information about some of the issues we'll be discussing today. Thank you also to Wayne Law and the Levin Center for partnering with us on this event, and particularly to Margot Laspiras, who is operating the Zoom and has been a lot of help ensuring the logistics of this event run smoothly. Finally, we wouldn't be here without the tireless efforts of Veronica Walrod, this year's symposium director. Veronica has been the driving force behind this entire event, and we have the pleasure of hearing from her as our moderator today. Our first panel addressed healthcare and access to care, and our second focused on opioid use disorder in the criminal justice system. In this final panel, we hope to bring those two worlds together, as well as broaden the discussion to consider the place of law in public health and vice versa. Thank you again for coming, and with that, I'll turn it over to Veronica to introduce our panelists.
Thank you, Ben, for the great introduction. I will introduce our speakers today. We are joined by Judge Patrick Shannon. He has served as the chief judge for the Saginaw Chippewa Tribe of Michigan since 1999. He also is a Master of Public Health from the University of Michigan and a graduate of the University of Detroit Mercy School of Law. He served as, before he became a judge, he served as an elected prosecuting attorney for Chippewa County, a tribal prosecutor and special assistant to the United States attorney. He recently has served as on the Michigan Prescription Drug and Opioid Abuse Commission and is as a board member on the Michigan Association of Treatment Court Professionals. He's a former chair of the Mackinac Straits Health System and a member of the American Hospital Association Governance Committee. In addition, when I was doing a survey of the field in the beginning to learn what I could about opioids in Michigan, his name came up multiple times when I spoke to treatment doctors very positively. And he was a great help in figuring out what topics we wanted to cover. Robin Fretwell Wilson is the Mildred Van Voorhees Jones Chair in Law at the University of Urbana-Champaign, Director of the Institute of Government and Public Affairs for the University of Illinois System. She also co-directs the College of Law's Epstein Health Law and Policy Program and co-directs its Family Law and Policy Program. She specializes in family and health law and science. Much of her work brings together law and questions of social progress and morality, including in public health, which is what drew us to her as a speaker. She's here today with co-authors, Rebecca Valek and Elsa Zwede. Rebecca Valek is an undergraduate student of public health and an intern at the Institute of Government and Public Affairs at the University of Illinois Urbana-Champaign. Assistant. Elsa Zwede is a JSD candidate at the Illinois College of Law. Courtney Anderson, our third speaker, is an associate professor of law at Georgia State University. She teaches law and social welfare as well as property. Her position there supports the university's Second Century Initiative, which focuses on interdisciplinary research into how law and policy impact the social, economic, and environmental determinants of health, particularly in minority and vulnerable populations, low-income populations. She writes regularly about housing and public health and has written recently historicizing the role of narratives around health and morality in the US response to drugs and to the opioid misuse epidemic. I would also encourage law students at Wayne State to look into her work. She writes about housing and health. She's written about Flint. These are issues that are relevant to, I think, Detroit particularly. And if you're on our journal, you should check out her work. And without more introduction, we will move into Judge Shannon's presentation. Thank you.
Good afternoon. And I'm assuming Good afternoon, and Margot, if I may, I'll just let you know when to move along. I've been asked to speak on our court's response to the opioid during a pandemic. And, it's a little misnomer because it was a few years ago, we had the opioid prescription problem, and that morphed into a heroin problem, which morphed into a fentanyl problem, which morphed into a methamphetamine problem. And so we're trying to deal, all the courts in the state of Michigan, I think across the country, are trying to deal with what we're dealing with, this methamphetamine, and how do we treat that. And next slide, please, Marco. And so I want to give you a background in federal Indian law in about 30 seconds, if I can. I did have the chance to teach this years ago at the University of Detroit at the law school. In Michigan, I can only speak as to Michigan generally, is that there are 12 federally recognized tribes. They all have their own sovereignty and their own courts. They have the legislative ability to generate their own laws, and then those are enforced in the tribal courts. So, and from the Saginaw Chippewa Tribal Court is located in Mount Pleasant, and it's the only one in the Eastern District of Michigan. But, I sit on cases, we're like a probate district circuit, everything combined. And I've heard wrongful death cases. I've heard dogs running at large cases. And we have jury trials as well. And the opioid crisis in Indian country, well, it's pretty much the same as what's happened across the nation. And what we did about 5 years ago, we developed a little longer than that, a healing to wellness program, which was adult in nature, dealing with people as to their, as clients rather than as defendants, and working with them. And we've developed that, expanded it into a family court so that people who have trouble with abuse and neglect situations or criminal, we try to deal with the family as best we can. We really look at public health. We've integrated public health into our court system here. One thing that you have to understand, you'll hear me talking about a few things and what we do with our clients, which can't really occur in state court because we have our own primary care clinic and dental clinic and behavioral health and a number of other things. And it's still extremely difficult working with some of these folks, especially now with the methamphetamine, because there is no real identifiable treatment modality. And then, about a year ago, it was indicated that I do have a master's in public health, and my wife's a nursing professor. My son's a Wayne State law grad, but he also is a nurse and he has an MPH. And so I put together a protocol for the court, which included plexiglass and thermometers, and you just don't get in here. But we've relied upon masking, spacing, cleaning, and meeting, and we've been able to operate as a court for the last year. I know that our friends in the state court system haven't been able to do that, but we've been able to do that. And it's extremely important to be able to meet face to face and then provide the online cases as well. I had 3 trials this morning, in fact. So, but anyway, next slide. Okay, so we deal with prevention, intervention, and treatment. Prevention, we certainly still rely upon our training and our education and community involvement, law enforcement. We developed a tribal action plan to promote this a few years ago. And then really now with our family court is with maternal, juvenile, adolescent intervention. Next slide. Our intervention, certainly our social services. One thing that we are different, I think, and which is good, is because I live in a really kind of a nursing education home, is that nursing has a different theory than the medical theory. Nursing likes to look at the whole person. And so what we have every Monday, we have our treatment court. I have a nurse practitioner in the courtroom who has conducted physicals of all of our, and working with a collaborating physician, conducted physicals assessments of all of our clients. Certainly we do, we rely on with a medical expertise as well. One thing I want to share with you is that the Michigan State Medical Society and the osteopaths and then the psychiatrists have been meeting for 2 years to develop really a program, but I think is similar to what we're doing. And there is planned for the next year regional trainings between the local medical professionals and the court systems throughout Michigan. And you'll probably know more about that in the future. And because it is a tribal court and a tribal community, you can rely upon the spirituality as part of the healing, and then the community, family, law enforcement, and certainly our court programs, healing to wellness. We've been very, I think, successful. It's extremely difficult dealing with some folks. You get them close to graduation or completing of the probationary period, and many times they'll start using again. Next screen, please. And then treatment, we use certainly medication-assisted treatment. And then I call it NAT, nursing assisted treatment. I think that's probably part of the biggest, I think it's just wonderful. You bring that kind of expertise into the courtroom. Cultural, spiritual teachings, maternal health, paternal health, hospitalization when necessary, and the psychosocial health, and then telehealth. We're building on that. The psychosocial is somewhat, I think, problematic. And also when you go back up to the MAT, medication assisted treatment, there's no magic pill. You have to look at different forms, including abstinence, works for some people. But you sit in the courtroom, you have to be able to, and I always tell people, you have to know how to set the drag. You just can't use sentencing guidelines or whatever to deal with each patient, because they're suffering. And not only are they suffering, their families are suffering, their kids are suffering. Next slide, please. And we certainly have interaction with the state, federal, other tribal courts. We meet quarterly with the state Supreme Court. We share resources. I've taken probationers into our Healing to Wellness program, tribal members, that is, from other who've gotten run afoul of the law in other jurisdictions. You have to foster trust. The court can't be a place where you're going to hammer down on people. It's a place where you settle disputes. And so we certainly promote rehabilitation, collaboration, and restorative justice. And we follow principles of the disease model and public health principles, and develop a client-centered justice system. So I'm very happy to be a part of this because you're groundbreaking. I tried to do this 30 years ago at U of M when I was a county prosecutor, and when I was writing my final research paper and looking at intentional violence as a public health problem, and they thought I was crazy. But they weren't ready for that concept. But I think today, I think there's the community and the educational organizations are a little more comfortable with this. And with that, Margot, I think I'm done here.
Thank you, Judge Shannon. I think that we can move to the next presenter, who will be Professor Wilson, along with Rebecca Valek and also Zoete.
Well, terrific. Judge, I think you're right. I think you're at the vanguard. And after, I'll send you some stuff we're doing on access to justice during COVID. It might interest you, a national survey that we have out. So I'm Robin Wilson. I direct the Institute of Government and Public Affairs for the University of Illinois. I'm going to ask Becca, my co-author, to screen share if she would do that. And first, just a big shout out and thank you to Wayne State and the Levin Center for hosting us in this event. I came to know Ben from something I did at the law school over a year ago, and he reached back to me. Like Ben, Margot and Veronica have been just absolutely wonderful in the efficiency and vision that they brought to this event. So I'm so impressed by what you've been able to pull off, especially during COVID. I want to thank Becca and Elsa, and you'll see why in a few minutes because they're so impressive. But the opioid epidemic as the judge said, is really a public health emergency, and it disproportionately affects those who are living in poverty. We've done some work at the Epstein program on the medicalization of poverty that I'm hoping my colleague will put into chat. But recovering from an opioid addiction requires building recovery capital, including a stable home, a home life, support, purpose, frankly. And the idea that we're going to propose in this paper is a big one. It is that those who are struggling with substance addiction need greater access to the services that will help them build that recovery capital. But this idea of a direct-to-consumer government, in effect, will also help any person living in poverty to access those services that America has committed to provide to them. Now, it may shock you, it certainly shocked us, but America spends 5 times more on poverty than we do on the military as a fraction of gross domestic product. And so that's $930 billion on the military, but over $4 trillion spent on various social safety net programs. Now you'll see some of the obvious contenders here, Social Security, Medicare leading the pack, but in the states, a lot of struggle to provide Medicaid, especially during COVID, and that's some work that we're doing at IGPA looking at that in Illinois in particular, TANF, SNAP, housing assistance, and the needs are just so huge. Now, we do a lot as a nation, but these social safety nets are fragmented. They're difficult to access. Other than Social Security and Medicare, people often don't know that they even qualify. And if they did, they don't know how to access that service. So our solution, you will see, is that we need something like Home Depot, a benefits depot, a one-stop shop for government services. In some ways, what the judge has been talking about with innovation in the courts is on a limited scale, bringing those services together. And we're going to talk about what it would mean to do this at all levels of government in a sort of very direct way. So let me hand off to Becca, and then to Elsa.
Thank you, Professor Wilson. So the Benefits Depot, our one-stop shop for government services, would need to be located centrally in the community where Americans can stop in and shop for the services that they're entitled to. So like a Home Depot, which stocks its shelves with all of your home and repair needs, the Benefits Depot will stock its shelves with all of your service needs, whether from various levels of government or from community agencies in the neighborhood that also are providing them that you may not know about. So the Benefits Depot concept will build off of existing models of engagement, much of which are embedded in the medical, legal, and criminal justice sectors. Traditionally, America has medicalized poverty, meaning we treat the diseases that result as symptoms of poverty rather than taking a more upstream approach. Private actors have begun to move more upstream and recognize the overlapping social, legal, and medical needs of the individual. Street medicine and mobile legal clinics take the services directly to the people, which is important for increasing access for hard to reach areas like rural communities and for hard to reach populations such as homeless populations and substance users. Medical legal partnerships are a model that embeds legal assistance directly into your medical care. So you may be going to the doctor and they will prescribe legal aid essentially. And this has been especially useful for substance users who have a high prevalence of underlying legal needs, especially custody needs. The Lake County Opioid Initiative in Lake County, Illinois, is a prime example of bringing the government into the picture. So they have a program called the Way Out program, which utilizes police stations as an access point where people can go into the police station and say, I'm looking for a way out. And they will be connected to treatment services for their opioid addictions without fear of criminal consequences for substance use and possession. And the Benefits Depot will similarly need to model this concept of a safe space so that people can come in and access services without fear of civil legal consequences, such as being served child support papers while they're there. Now, all of these innovations are great, but they are limited by the sectors in which they exist. And most of them require you to already be in need of medical care or already embedded in the system, already involved in the system in order to receive the help that you need. We need to move further upstream in order to help people before the point of crisis. And this requires bringing the government into the picture. This requires a Benefits Depot. Now, we've already seen some examples of this model in the government, mostly through individual legislators and through executive branch agencies. Some examples include mobile city halls, legislative constituency fairs, and online resource databases. But as you can see, these websites are text heavy and difficult to access for those without technology, potentially broadening the digital divide. And in-person services are often limited by providing services from the agency that is directly providing the service or the individual level of government providing the service. So the Benefits Depot will build on this concept and provide services from all levels of government and all agencies in a more comprehensive manner. So these are just some of the sectors that with services that the Benefits Depot will provide. And these services will include both enrollment in and education on the government services that you are entitled for, as well as connection to community agencies and nonprofits that offer services in your area. All of these actors will need to be involved in the Benefits Depot because they all are part of the one-stop shopping that Americans need if we want to pull everyone out of poverty. So just as an example, within the housing sector, the Benefits Depot can offer access to government benefits such as weatherization assistance programs, Section 8 housing and fair housing, as well as connection to community organizations like homeless shelters and affordable housing agencies that offer programs. Now, various government agencies and just general community groups have utilized kiosks to increase access to care and efficiency of services. During COVID-19, we've seen an increase in kiosk use in the courts through the Access to Justice kiosks, where people can go and utilize this kiosk to attend their courtroom virtually if they don't have their own access to reliable technology. DMVs in a box and global entry point kiosks have also been used to increase efficiency and decrease wait for the services. Similarly, the Benefits Depot can utilize the kiosk model to allow every agency with representative services to have a kiosk and a representative at the Benefits Depot, thus allowing them to still work out of their existing agencies and buildings, but remain forward presenting to the public. Now I'm going to pass this over to Elsa to talk about the benefits bus concept.
Thank you, Becca. The benefits bus will bring the Benefits Depot services to the people in rural and hard-to-reach areas. The benefits bus concept builds off existing mobile aid models that have been effectively used to bring services to the people. For example, the mobile legal clinics bring legal services to the people. Street medicine and the night ministry brings medical services to the people. The benefits bus will park in places where people congregate, like homeless shelters, post offices, and federally qualified health centers to create awareness for government services. The rationale of using the benefits bus is to overcome transport hardships, reduce bureaucracy, and make the benefits depot services easy to find. The bus is a shortcut to zoning restrictions and NIMBYism, therefore a step to reducing stigma within the community. The Citizen Scientist Journaling Project proves an urgent need to bring services to the people. For example, the theme across the 3 citizen scientist stories shown in this slide is that it is tough to access services, most especially in rural areas. Bringing government to the people will be more responsive. We will be delighted to share more about the concept and answer any questions. Thank you.
Thank you. That's great. I just want to remind everyone quickly that if you have any questions that you think of, feel free to put them in the Q&A, or if you have comments or just want to talk about the presentations, that can go in the chat. And with that, we will move to Professor Courtney Anderson.
Hi, thank you, Veronica, and thanks to everyone at the symposium and at Wayne State for organizing this important discussion. Really want to say thanks to my fellow panelists for all the information that they provided. This is such an important topic, and I think we're all kind of bringing different ideas and different perspectives to this issue, and we all definitely look forward to the Q&A session. So I hope to hear from all of the participants to get their perspectives as well. I'd like to talk today a little bit about the narratives surrounding the opioid crisis in comparison to the narrative surrounding the crack epidemic in the 80s. And so my area of research and scholarship primarily focuses in health equity, focusing on racial disparities, mostly in Black communities, and looking at how different economic perspectives influence these disparities. So I think that when we talk about the laws and the policies that are created around any type of drug crisis, it's important to understand it from a historical perspective, what type of racial inequities might be perpetuated by any type of solution or by any type of framing of narratives, given that the voter base really succumbs to media images and portrayals, and therefore influences politicians, and that's how laws and policies are set. So I'm sure I won't tell you anything you don't already know with respect to the war on drugs starting in the 80s, say with President Ronald Reagan. This is when the slogan really was popularized. And by 1984, over 4 million Americans were using cocaine. And so President Reagan wanted to really turn this around. And so in this same year, he employed the National Strategy for the Prevention of Drug Use and Drug Trafficking. And this had the goal nationally to conquer drug abuse and ensure a safe and productive future for our children in our nation. So even in the slogan, we're really kind of family focused, which was a really big trend of this administration. And then in the mid 80s, we also saw the rise of crack cocaine, especially in inner cities and large urban metropolitan areas. And the 1980s, in response to this, this major anti-drug law, the Anti-Drug Abuse Act of 1986 was passed. And this act really established this precedent of mandatory minimum sentences. And this is really important. I'm sure you've discussed this earlier in the symposium, because we'll talk about the unfairness of how it's applied depending on what drug is at issue. And so the Anti-Drug Abuse Act of 1988 distinguished crack cocaine from both powder cocaine and also other drugs, and creating a mandatory minimum for just simple possession. And so crack is the street name for cocaine, for the form of a cocaine base. But there was this sensationalized media coverage causing public panic as politicians warned of the availability of this cheap and highly addictive, deadly form of cocaine. And because the affordability of crack cocaine really opened up this new market of use in low-income communities of color, it was more valuable because it was so cheap and it was so much easier to make. And we saw really huge disparities between powder cocaine and crack cocaine. And despite cocaine's status as a Schedule II narcotic, cocaine use was rapidly attaining this kind of unofficial respectability. It was accepted as an innocuous stimulant and was framed as something that upper to wealthy people used as a way to kind of end or start a party. So cocaine was gradually spreading in the upper middle class, while this media coverage of crack skyrocketed. And the media coverage was really focused from a racial perspective on the dangers of crack and how crack users were violent. In fact, 3 major TV networks offered 74 evening segments on drugs in 1986, just in 1 month, in the month of July, and half of these were about crack. So despite that crack cocaine and powder cocaine are virtually identical chemically, the media portrayed crack cocaine as a substance far more addictive, much more menacing than powder cocaine or really any other drug. And this violent crime connection with crack cocaine was really sensationalized by the presidential administrations, both Nixon and Reagan's administration, on their get tough on drug policies, and really were using this to shape public perception. And so following this war on drugs slogan, you saw a lot of lawmakers in the news kind of warning about the dangers of crack. Media coverage of drug use increased, sort of reinforcing this rhetoric that perpetuated this unequal treatment of powder and crack cocaine. Terms such as crackhead by the mid 80s was a really popular moniker for how we frame these drug addicts. We also really focused on crack babies and the focus on how these mothers were not caring for their children. So all of this widespread fear was that this would spread outside of these urban city centers into the suburbs. And so in response, there were a lot of strict laws and policies to combat this. And this mass hysteria really over crack cocaine in the 80s took all of this imagery, emotions, and predictable policy responses of prior panics and really ratcheted up a notch. And so, in fact, judges really made observations. In fact, Judge Clyde Cahill in U.S. v. Clary observed that while it may not have been intentional, it was foreseeable that the harsh penalties imposed on Blacks would be clearly disproportional to the far more lenient sentences given to whites for use of the same drug, which is cocaine. And when we were looking at the sentencing mandates, we saw that Congress divided the threshold for powder cocaine, 5,000 grams by 100. So therefore, 50 grams of crack cocaine is treated the same as 5,000 grams of powder cocaine. And this 100-to-1 ratio was really controversial since it has a disproportionately high impact on Black Americans and also on low-income Americans. And we're getting two separate mandates because we also had the imposition of mandatory sentences for effectively the same drug. And we really saw in the 1980s this transformed as a national crisis. And so these mandatory minimums were justified as a response to stop and control this violence that was perpetuated in the media. Bills to address this disparity were introduced pretty much annually from 1993 to 2009. Each one failed. It wasn't until the mid-2010s that we saw traction to remove these mandatory minimums. But by then, we have these unequal incarceration rates in our criminal justice system, really stemming from this narrative portraying the crack user as someone who is dangerous and really framing it as a problem of Black Americans becoming violent and reacting to this drug in a different way. And if you compare it to our use and framing of the opioid epidemic, which really hit and ramped up around 2010, the number of babies born with opiates in their system at this time increased fivefold from 2003 to 2012. But while you might be familiar and really in the media, this narrative of a crack baby and the crack mother who didn't care about her children was pushed, we did not see that same narrative around opioid users. And 80% of Americans opioid overdose victims are white. So when we see this comparison to who the users are, we really see the change in narrative. And so now we see that opioid users are really framed as addicts with a mental health condition rather than these violent criminals. And crack users just were not given that fair treatment. And we also see that the focus on treatment of drug use, of prevention of the opioid crisis, doesn't place as much blame on the user as it did in the crack epidemic. And therefore, we have laws and policies that are focused around treatment. We have drug courts, we have expansion of Medicaid in order to treat this as an actual addiction problem rather than punitively with harsher sentences and framing it as a criminal issue. And when we see the differences in the races, we can see how these affect different people. And, overall, I think just like the role of implicit bias really cannot be overstated. These implicit biases, they develop in our subconscious, and it's really due to these repeated negative associations, especially when you're talking about association of a race with a certain crime, and then establishing these pictorial images of, our most vulnerable, desperately people who are in need, which are babies, which are children, as suffering at the hands of a Black mother or a Black father. And over time, these repeated negative associations establish neurological responses that are responsible for detecting and quickly responding to danger. And so this formed the societal narrative that African Americans are intellectually and socially inferior, have a natural propensity towards violence. And we can see this in the differences in the criminal justice system, which carries over then to access to healthcare and insurance and all of this desperate treatment within the healthcare system. And overall, I think we just need to be observant and conscious how the media serves to perpetuate unfounded fear and stereotypes among the voter base, which then manifest into policies and laws. And I definitely look forward to talking with you a little bit more about this in the Q&A.
Thank you to all of our presenters. I think everyone did a really great job. We have a couple very interesting questions that have already come up in the chat. The first one is directed at Judge Shannon, but I think that probably anyone that brings something to mind for can answer. Someone asks, do you think the methodology that your court has implemented to address substance abuse can be easily implemented in current drug courts? Or do you think there would need to be a substantial overhaul of the current drug courts outside of your own tribal court that has some extra direct access to certain supplemental resources in order to make them ideally effective?
Yeah, and I think I mentioned that we're in a little different situation because I work on a separate sovereign from the state of Michigan, and the folks here have access to primary care, including dental and some behavioral health as well. And the question is can they replicate this? And we're starting this discussion this year with the Michigan State Medical Society and the Michigan Association of Treatment Courts. And so we're just getting started. And I reached out today to Central Michigan's Medical School and their School of Public Health to get them involved. But I've told them also, I said, you've got to get the nurses involved. And so, and then, you know, there are parts of the state of Michigan that just don't believe in any medication assisted treatment. It's law enforcement attitude. And I came from a very strong law enforcement background, but have soon learned that we're now in the business of saving lives. And so there's just, it's going to take time, and it's going to take a lot of education. And, you know, you have organizations like Families Against Narcotics who are out there working, but there's a very strong criminal justice attitude toward this that still remains. And, you know, I think a major obstacle are your judges who are elected officials, and they have a constituency that they have certain beliefs. Last year, no, it was 2019, I spoke at a state judges organization, and along with a specialist, a physician specialist. And there are some judges who just were, their attitude just didn't believe in any of this. It's, you know, it's easy to put people in jail. It's easy to figure out the sentencing guidelines and push them into that. But I don't have to deal with that here. I have jurisdiction to put people in jail up to 1 year. And I rarely, if at all, do that. Sometimes I have to put people in jail, but I like to look at alternatives. But so my answer would be, it's going to be a long time because you're dealing with politics. And but it has to be done at the local level starting.
That makes a lot of sense, and it draws attention to the fact that the legal justice system is at a county by county level, where the politics aren't necessarily what we are used to thinking about, which is state or federal. Does anyone else have anything to add on that?
I can even add to that is I live in the Upper Peninsula, but I work in the Lower Peninsula, or below the bridge, as we refer to it. And they don't believe in medication-assisted treatment there. They don't believe in Suboxone or the use of Suboxone or any forms of medication-assisted treatment. And because it's been abused, I believe. And so I know the Michigan Association of Treatment Courts have been up there several times in the last few years trying to do training for the local judges. But like I said, they're elected by a constituency that may have certain attitudes.
So we have a question that kind of relates to attitudes about medicated treatment, and it relates to something that came up in our last panel, and I'm just going to summarize for audience members who might not have been there. One of our panelists pointed out that when a pregnant woman tests positive for methadone, even when it has been used as part of a medical treatment, she can face criminalization, and so people will feel very fearful about accessing treatment that they need or that a doctor would allow them to have that might prevent overdose, because they're afraid that they'll be moved into another part of the system, which also relates to something that Courtney, Professor Anderson touched on. But our question is, what policies can be implemented to address neonatal abstinence syndrome while keeping mom and baby together, while reducing, or at least not increasing, the moral hazard? In other words, how do we ensure pregnant women who are using opioids feel comfortable that they won't lose their child after birth to Child Protective Services and come forward so that physicians can properly treat early? I know that that's a little bit technical, but if anyone has something on that. If not, we can move on to the next one.
No, that's okay. I mean,
I deal with this in the courts, and we always strive for reunification. The worst thing you can do is separate a child from their mother. I mean, it's just absolutely if you're really dealing with the rehabilitation and treatment, you can't do that. I mean, and there are associations, the Family Court Association, the National Association of Family and Children Court, that they've written about this. And I see it. That's just wrong-headed at many levels. But I know there are others who want to wait. So.
No, I was just going to say, you know, we have in the family law context models for making sure that people can take steps that are appropriate, like, you know, safe haven laws, for example. I mean, of course, that's actually relinquishment of your child. But I think sometimes the problem is the positive law, that we have to put people in the position to be able to access these services. And then there, to go to the benefits depot idea, there's actually a great service need. People need to be able to know about that. But one of the things that we see persistently with especially, you know, drug involved mothers is that for them to put themselves in rehab, they have to leave their children, but they don't have a caretaker for their child. And so they're put on this path of having to pick a fork. And that's where the mistake happens, is that we're forcing them to a decision to care well for themselves and to get their lives back together or lose their child. Now, kid networks, you know, mediate this. You know, lots of my mother raised her grandbabies and her great grandbabies, right? So, you know, kid networks can do a lot of this work, but we only really ask that of people less in our society, right? We put them on this choice, whereas wealthier people, you know, have the resources to be able to make that work out. And I think that's a tragedy.
I think another concept, and it's one that I mentioned briefly in the presentation, is medical legal partnerships in their use in substance use treatment. So if an individual is receiving treatment for a substance use disorder and the treatment program utilizes a medical legal partnership, then the doctor can prescribe legal aid, and then the person is aware of what their legal needs are, because that's a huge issue. People just don't even realize their legal needs or their legal rights. So they may have these underlying custody issues and just have no idea how to go about it. So by combining these services, by allowing them to have this legal care, this legal aid and this medical care in one place, and just telling them like, no, you have a right to this legal assistance, and these, like, we can help you with this, that can definitely help with that, where otherwise women don't even necessarily know, oh, these are my rights in keeping my child, like I am allowed to be on MAT. And so then they're not going to take any action, and then it's going to be a lot harder for them to stay together with their child. So I think medical legal partnerships in this kind of case are very important.
That brings us, I think, pretty neatly into another great question, which has been a little bit touched on now. A few of these concepts in the benefits depot, like the kiosks in particular, seem well situated when you know what you're looking for, but often people don't know to even look for things, let alone how to ask for them. In access to justice terms, only 1/5 of people even know that they have a problem that might have legal solutions. How would you address education about what might even be available to people? In other words, how do you advertise such an expansive universe of potential needs that can't be summarized by a simple slogan like "for all your gardening needs"? How do you encourage people to step forward and ask what might be available to them on such a wide range when individual needs are very specific, and people will often lack the knowledge to ask the right questions from the start? And I would like to add to that, because I think it's related. How do you address the problem that people might be fearful based on their previous encounters with, or just their knowledge of how their community has interacted with legal systems in the past, particularly for marginalized communities?
Well, let me take first crack, and then I'll invite my co-authors to weigh in. So look, I think the healthcare system actually offers us an important model here. My mom just recently had an episode. She's a diabetic and is 84 years old and went cartwheeling on a drug. And you know, the healthcare system right now in the middle of COVID has so many rules and regulations, like it wasn't already really regulated, it is now. And you know, one of the really great resources was an ombudsman at the hospital who could walk you through the sort of maze of regulations and let you know who is involved in, you know, what piece of the care. Okay. At discharge, there was a care manager. Okay. The benefits depot needs to have ombudsmen, literally need to walk, you know, people who can answer your questions. You know, the little chart that Becca and Elsa put together for the paper looks like a conference center. I'm sure Courtney's going to the same AALS meetings that I go to, and you go downstairs where the booksellers are, and there's Cambridge, and there's, you know, so-and-so, Barbary, and there's so-and-so, and you walk around and you sort of understand from the people at those desks what they are there purveying. We need the same sort of concept, except we have got to collapse these very multiple layers of government into one place. That's the innovation of the Benefits Depot, that you don't have to go to your local city hall and then over here to Social Security office in Chicago and then over here to the state and local government and try to figure it all out by yourself. So I think that's one innovation. I think Steve's question is really spot on, and your question about you know, breaking through the disinformation or just, you know, frankly, no knowledge of the thing with ombudsmen or people who can assist that process. I think your point is a really profound one, Veronica, about trust and about breaking down barriers. But look, if you can go to the Benefits Depot with your grandma or your mother and suddenly her heating bill is taken care of, and she goes to church on Sunday and tells 3,000 people in this big mega church that her heating bill was taken care of, there's going to be problem solved. Okay, it will take care of itself very, very quickly because we have very, very robust civil society organizations that are very invested in this. So I think we have to demystify it. We literally have to do direct to consumer government. And I think when people see that working, it will work. You do have to throw promises down in these places, though, that you can't be served legal papers or, you know, a bench warrant or whatever. And we had a long discussion as a group of authors about this exact point. I'm sure the judge is not going to, you know, if somebody's being violent towards another person in his courtroom, that is going to get solved. Like, you couldn't allow this to be a place that is like a completely criminal justice free zone so that one person is, you know, subject, you know, vulnerable to another person. But this should not be the place where government finds people that it's been looking for in particular ways, the criminal justice system. And neither should private attorneys be able to hover around looking for people coming in. But if you can make those two things work, I think the word of mouth would take care of itself. I really do.
Kind of building on that, yes, I think that your two questions are really at the root of why we need a benefits depot. Because right now, with the existing models of engagement, people are only engaged in the government, not only, but largely engaged in the government when they're in crisis or when they need help. So their experiences are largely negative, and then they don't trust the government. They don't recognize the good that the government can do for them if they can find the services. And so that's why it's needed. But I definitely agree with like using kiosks and everything. Some people don't necessarily know, like, how do I use this? Or if there's so many services in one place, people may just feel more lost in that. And that's why I agree, like having someone to walk you through it. And also, it won't just be a kiosk. It's a kiosk and a representative from each service, so that there's actually that live person there, so that you can have that in-person connection and actually ask your questions, and they can help you navigate your services. And then I also think just the fact that it's not just government services, it's connection with community partners, because community partners know the community, they know, and a lot of them are trusted by the community. And so by building those connections and building those relationships, they can help you with that whole trust aspect. They can help you get closer to the community. And the benefits bus portion of the concept, which goes into areas like parks outside the post office. Post office is the most favorable government agency, and it's the most utilized government agency. And if they park outside the post office, you're going to have a lot of people just walking by, and then all of a sudden they see this cool benefits bus, they say, oh, what's this? What are you doing? You explain the concept. Maybe there is one in their neighborhood. They know to then go there, or they can access the services right from the bus. So I think there's a lot of different pieces that kind of help to resolve these issues. Obviously, working with trust, and especially in communities that have historically been disenfranchised and disadvantaged, it's going to be a lot harder. But I do think that the Benefits Depot is part of the solution to bridging those trust gaps.
I want to make sure if Elsa has anything to add. Just because she's my PhD student, I want to be sure she keep going, Elsa.
Actually, Becca said what I wanted to say about the benefits bus, but I think what I would add is we will map and do a needs assessment in the community. So we will be aware after the needs assessment and mapping and working with the people that are already in the community, we will know what services people really need, and we will know how to refer them to those services they need. Yeah.
No, that's a great point.
So we have another question that goes also to the logistics of a benefits depot, and I think it addresses kind of the ethos of it, which you've been talking about, which is would it be located in primarily disadvantaged areas, i.e. would it be a strategically targeted service that, or would there be no distinction between high and low income areas? Would it be targeted by being universal? I know that that is more of a practical question on a like extremely big policy idea, but.
Well, we picked post offices. If you followed any military base closure debates ever, they don't get closed easily. The post office will be with us forever, and they're everywhere. So I'm sitting in my home in North Carolina, really to have been closer to my mother while she's had this issue. And there's a post office every 10 feet. I mean, no, I'm exaggerating, but they're everywhere. So you could just drive your little benefits bus around in some circle, you know, place to place. If it were me, just again, sitting in North Carolina right now, but also this is true of Southern Illinois. I'm sure it's true of Georgia, Courtney, but I'd co-locate this thing in a Walmart parking lot. Walmart should want to be doing this. And I'll also say that historically disenfranchised, I mean, even when we're talking about this issue, if you just think about it, I really appreciated Courtney's remarks about how we've been so inequitable at the way we've enforced these laws. But this has ravaged the Appalachia. I mean, one of the people writing for the Medicalization of Poverty Symposium was a former health commissioner of Virginia who talked about Virginia as really 3 different states: Northern Virginia, DC, the Tidewater area, and then Appalachia. And I think we have to think like that. The asset mapping and the need mapping that Elsa's talking about, I think would lead us to do different things in a Northern Virginia than in DC than we would do in the Tidewater, than we would do in Appalachia. What we don't want to do is look only at one community. I think there are needs that run all. I think it would surprise you if you sat down with your own neighbors, you know, just the degree of need, especially now in COVID. So I think, you know, we need to be very, very thoughtful about the way in which we consciously reach to people. I will say there's one thing that we're eliding in our paper. And so the student editors, please just ignore what I'm about to say, but we're treating this as if it's fiscally neutral. It will not be. People don't know how to get these services that America has committed. And if the degree of need is as great as I believe it, we might not be spending, you know, 5 times the military, what we spend on the military. It might be 20. I mean, pause and think about that for just a second. The Coronavirus Relief Act that Biden signed spent more in just this period of time than we spent in all of World War II. I mean, just pause and think about that. So I want to go everywhere with the benefits bus, and I want to build benefits depots everywhere. The only question is, do we have the money?
So we have a question that I think actually goes to everyone, because it gets to kind of like being able to do policy changes in a democracy, especially on a local level and things that might have to be targeted. We talked a little about the media's role in perpetuating the opioid epidemic, specifically in the past, but has the media today changed at all away from marginalizing those with use disorders? If not, how can we help change it? I think that this goes to the American attitude about the social state, the problem of some electorates who still really favor law and order approaches that don't necessarily always work with health issues, and also to the drivers of policy approaches, especially regarding whether improvements that we see around opioids will make it to more heavily stigmatized drugs. So if anyone wants to take that, that'd be great.
So what's the question?
The question is, what can we do as legal actors or maybe as law students to try to change the attitudes that make it difficult to create change and to make that change systemic and large.
For those of you who are law students, this is my recommendation. Get into the courtroom and try cases, either in defense or prosecution. Bring those attitudes with you. Courtrooms are wonderful places. I mean, and I've been listening to the kiosk concept of services. You can turn the courtroom into a kiosk. We're not providers here, but I have an incredible staff that goes out and finds the services for our folks and then monitors that. Certainly we're not mental health workers. We're not medical or nursing. We do have a nurse practitioner on staff, which is invaluable, but this is kind of a kiosk without being a kiosk. And I'll just share with you, 2 weeks, or it was a week ago, a couple of kids, young girls were placed in a foster setting and it wasn't working out. They didn't go back to the the human services department. They ran to the court for help, and that's the way it should be. This should be that place. But my recommendation to law students: get out there and learn how to try a case. Do jury trials. Get your butt kicked a couple times, but that's the best way to learn and have an impact, I think. That's just my 2 cents.
So Judge, the only thing about this view is it scares the bejesus out of a lot of people to be in court. I want to take this to Walmart. They love going to Walmart. Post office is a place where we socialize. So I'm with you. I applaud you for taking such a big picture view of the needs of the people in your courtroom. That is super, super huge. I think one thing that law students can do, bring your bold ideas. The Benefits Depot is an idea that we spitballed around my Zoom table, our kitchen Zoom kind of conversation, but it's right. We're seeing it at levels of government actually struggling to figure out how to engage. Government's not all bad. So, when you see innovations, applaud them. Call them out, lift them up, and then ask, how can we scale them? How can we do more with what they're doing? We have a call next week with the gentleman who created the mobile city hall for Chicago. We can learn from that experience and then hopefully put it on steroids. That's the idea. So, and this isn't, I like to think, I'm really smart as a law professor or whatever, but it doesn't take any law professor to figure this out, right? It doesn't take a law professor to figure out the government is not working. People can't work through this maze, right? This from just talking to your own family. So ask then, how do you get to a better outcome? I think that's one of the great promises of law school, that you instantly, are going to have the status, the stature, the chops, the analytical skills to go change the world. So that's what you should be there for.
And then run for prosecutor and then judge. You want to have impact in the courtroom. Run for prosecutor. And prosecutors have more authority than a judge does because they make the decision what's going to be prosecuted. And that includes child abuse and neglect. And it includes the criminal justice system. I had a guy tell me one time that a prosecutor makes more decisions in one day than any judge does. And that's absolutely the truth. So, you know, you're going to have a license to do this. So get involved. You know, and there's some, you know, the guy up in over in Ann Arbor and Washtenaw County is shaking it up among the other prosecutors in the state by he's not going to take certain types of cases. And you have to do that at times. And you would have the authority to do that. And the jobs are pretty good too. They pay well.
I also think just tying it back to the media, I think in terms of like how things are today, the media is not just the newspaper, it's not just the newscasters. Like we create the media. With social media, like you can influence the media yourself. So I think an important thing is remembering that we all know about different, like we all have different interests. We all know about different things. I'd never even heard of a medical legal partnership until I met Elsa. So using your platform on social media and the media generally, you can influence how the media talks about those with opioid use disorders. You can recognize when people are using stigmatized terms and call them out. You can post those little informational things because sometimes people may see that and be like, I never knew that before. I learned from, it was actually from someone's Instagram story post that I learned that marijuana is a stigmatized term because it was created in order to make it more negative and make use more negative towards Hispanic people. I didn't know that before. So we have control over the media to some extent, and in whatever way you can, use it. Use your platform to influence how the media views these and to help decrease the stigma.
Yeah, and also in relation to what Becca said about the media, I think if the media is showing the negative story, then we need to create the positive story. So when we publicize the good things that we're doing, like the benefits depot and the benefits bus, and talk about that a lot, I'm confident that the negative story will drop and our positive story will attract more attention. And therefore we'll have positive media about opioids, and then maybe that way stigma will also reduce. And if we, for example, for the benefits bus, because it can shortcut the zoning restrictions and everything, I think that's a nice way to end the NIMBYism aspect of don't put it in my backyard. And I think that's also a positive step to stopping the so much stigma. So yes.
Okay, our next question asker says these ideas are wonderful, but I would like to ask Professor Anderson, the idea of overcoming the stigma between the legal system and poor disenfranchised of color seems incredibly overwhelming in the wake of events like the murder of George Floyd, as well as I think that they're probably thinking about the historical events that you covered as well. I would like to hear Professor Anderson speak about how she approaches this issue, and then because we're at Wayne State, they say specifically in a community like Detroit, where it is front of mind dealing with the city and their population here.
Oh, sure. Yeah, I understand it must be front of mind in Detroit, similar to Atlanta where I am. So I think there's a lot of similarities between the cities. And unfortunately, you don't really have to be in a big city to kind of understand how widespread this issue is. But it is, I agree with the person who asked the question saying that it's overwhelming because it's something that it's not like a milestone that you can achieve and then sort of racism is over. It's a constant process, and the types of disenfranchisement evolve and change with every passing law and policy, and they often serve to exacerbate this. I mean, you can take the pandemic as a perfect example. You know, it affects everyone's in the pandemic, but when you see, for example, housing laws and how they're applied, when you see people of color being evicted at much higher rates and being affected by COVID at much higher rates, and there are also the people that are, you know, disproportionately in these essential worker positions with everything that happens. But then everyone gets the same amount of money from the stimulus. So there's sort of this kind of one solution for everyone, even though we have these disparate impacts. So as far as how we can address disparate impact, I really think it has to deal with a system approach and understanding that we've rebuilt systems before and we might have to do that again, because there's so much racism and inequities inherent in the structures that it's difficult to just simply kind of pass a law or to do one simple reform. So I think just like understanding what we can do to create a new system. I really like the idea and really enjoyed hearing about the benefits depot, because I feel like that's a perfect example. Like we really need to go out of these common frameworks and structures that have proven to be completely ineffective and really be innovative. You see innovation all the time in the private sector with respect to technology and any other product that you would buy. But when it comes to social issues, we do the same thing over and over and over again. So that type of innovation is really necessary in the legal context as well.
I'll just add on, I wear this new hat now, helping faculty across the 3 systems try to translate their work. I'd love to talk to you about that, Courtney, at some point, because your work is so fascinating. So I'm putting a little bracket around myself as an individual scholar, not speaking for the university, but one of our early drafts, I'm like, hey, look, Uber Eats has figured out how to deliver stuff to us during COVID. Can't the government do that? I mean, like, stop for a second. Uber Eats has come from nowhere. Everybody has Uber Eats. Why can't we have a benefits depot? And the interesting thing is we do have that. We've had those innovations. We just have had them for DMV, but only DMVs in the kiosk. That's the thing that's so insightful about the judge, but also the move to therapeutic courts, drug courts. People's needs come and they're complex like people. They all come together in these packages. Government needs to be responsive. So many other things have changed in COVID and we've innovated. So government needs to innovate too.
We have a question that kind of goes to that idea that the private sector or the quasi-private sector sometimes has different abilities than the government or has developed in different ways. The question is, how well do you think nonprofits already serving these populations, like drug users, people that use opioids, either prescription or not, could be leveraged by making sure that their resource centers and appropriate staff know that legal solutions may be available to the various problems their clients may face? I would like to add to that just a question about what the relationship between the existing nonprofit infrastructure that has kind of a place in our government's health workings, often where there are gaps in what's publicly available, how that relates to the benefits depot, or even to creating a comprehensive drug court program, either of those.
Let me take a crack at the first part. That's a great question, Ben, and really like the amendment, Veronica. Look, I think the real risk here is that you never want to displace those organizations that are doing really valuable work right now. Some of you know that I do a lot of work in the culture war. And I'm actually adopted, so I'm very, very concerned for religious adoption and social services agencies to be able to stay in the marketplace. I don't want them to be discriminatory, turning people away. I think that's not good. We have a case right now before the US Supreme Court about just this. But one of the things that we have to be very, very careful is to try to keep them in the community. Why? Because people, faith is a very big thing for many, many people in their lives, especially when they have a vulnerability. And if a faith organization connects to them in a different and unique way, or a Sierra Club, it doesn't matter. It's not about faith so much as just, people having a sense of identity with an organization that does good in the world. We need them to continue to do that. What you don't want is the benefits depot to be crowding out those things that have been doing well in the world because people connect to them. You need the benefits depot to cooperate and work in tandem with government and civil society organizations. It can be literally like that chart that Becca showed. There should be like a whole part of this, conference center basically, or one-stop shopping place that is for the things that already exist, not displacing them, but cooperating with them in tandem. So I think that's really important. You know, the picture of the night ministry. So I've gone around with the night ministry on their street med van. They're doing a huge amount of great work for homeless folks. They have, you know, right there in the street medicine ministry van, some very limited forms. You know, how do you get your mail forwarded to a family member if you're homeless because you don't have a post office box? How do you get a medical power of attorney? You know, they can help with some of those things. You know, I think it's difficult for them to do a whole lot more because, you know, they're already stuffed full of all the meds that people need, you know, sort of urgent care on wheels for the homeless population, that type of thing. You know, the way that these existing things like the street med team should be used is to triage, and in effect to let these folks know, okay, here's the benefits depot here, and there are these people here that can walk you through the other parts of your needs besides just this medical need. And I think they can be eyes and ears in the community. And I don't know about the drug court piece. I'd be interested to hear what the judge says, or Courtney or anyone else on that point.
Just a quick comment adding on to that is that in the paper we talk about how for the benefits depots, when you go into a community, you would start by doing a community needs assessment and by doing asset mapping. So in doing those two steps, you determine what are the major needs and interests and concerns of the community, and you determine what's already there, what's already being provided, so that you don't leave out these nonprofit and community organizations that are already providing really valuable services. And in doing that, you'll also end up building relationships right off the bat with a lot of these community organizations, which is essential for community engagement. So I think that would be a good way to ensure that you're not crowding them out, but instead lifting them up and bringing them together.
Yes, and also because trust and relationships are very important when people are getting services. These nonprofit organizations already on ground have already created those relationships with the people. So at the benefits depot, working with these people who are already within the community and have already created relationships with the people will help us so much to ensure that those people can actually go out and get the services that they need. So I feel like it will be, like Professor Wilson said, more of collaboration to ensure that trust is maintained. Yeah.
Okay. We have one question in the Q&A, which is kind of specific, but I'd be interested to know if anyone knows about it. The question asker says, has the slow state-by-state legalization of marijuana had any impact on the opioid use epidemic? i.e., has there been any shift that any of you have seen away from opioid use to marijuana? I assume that they mean as a now widely available pain treatment that is in many places legalized, or not, or more accurately is decriminalized.
I haven't seen any change. I mean,
No.
There's still people are overdosing and dying. One of the concerns, and I started answering that, and easier to do it this way, is that we've been part of something called the Office of National Drug Control Policy, and on a monthly basis they have a meeting, and they split the United States up into regions, and we're in the Midwest region, but I take part every month. And in the beginning it was just law enforcement. Now and about 3 or 4 years ago, they expanded it. They have half as public health, half as law enforcement. So they've even recognized that this is a public health problem. But you know, what you're seeing in other parts of the country is the existence of fentanyl inside of street marijuana. And so it probably the legalization or decriminalization of it probably may do a better job at keeping fentanyl off the streets, because that's what's killing people now. As I mentioned earlier, is that we've seen this, and I know a professor had mentioned about the crack cocaine and cocaine, but then it was the prescription drugs, and that morphed into heroin, and now we're seeing more cocaine, but it's methamphetamine and fentanyl, and cocaine's being cut with fentanyl. It kills people now. So it's been this movement from opioids over into the stimulants, and I can't think of another court that isn't dealing with the influx of methamphetamine. So the marijuana stuff, I don't think. No, I don't think it had an impact. My concern is people buying it off the street and it's laced with fentanyl. That's a concern.
Yeah.
Kind of speaking on that.
That tempers some hope that I think a lot of people have that it's a viable pain treatment, but when the market still exists and it's pushed by the same forces as other illegal drug markets are, it does still remain dangerous.
And I can tell you as a prosecutor, years ago doing homicide cases, it's usually fueled by alcohol. I never saw someone blow another person's head off with after they smoked a joint. It was usually Jack Daniels.
Rebecca, were you?
Sorry. Speaking on the marijuana, the cannabis use and opioid use relationship, I actually do work in a different position than the one I'm here with now. I work in a research lab at UIC studying social media data of marijuana dispensaries in Illinois and their accordance with the Illinois Cannabis Tax and Regulation Act. And one thing that so I kind of have some background knowledge on this, and I think the main conclusion is that there is no conclusive answer to that question right now. There have been studies that have said, yes, we report a decrease in opioid prescription and in states that have legalized, and a decrease in opioid use, decrease in opioid deaths. And there have been other studies that say, not so much. So I think it's just still something that really needs to be studied. There have been some promising studies showing some modest decline, but nothing super substantial or definitive. I also think in terms of the whole pushing people away from street markets, that is definitely something that was considered at least in Illinois, and I'm sure elsewhere, in the passing of the legalization of cannabis, because they wanted to put a tax in that made the program effective and created revenue, but they didn't want the tax to be too high that just pushed people back to the street markets. So I think it is something that was considered, because it definitely is, the bigger danger is not just marijuana use, it's marijuana use if it is laced with other substances that can be extremely dangerous. So I think we've seen some decline, hopefully, but it still needs to be studied.
Thank you. I have another question for Judge Shannon that comes out of some of this discussion that we had in our last panel. We had some of our panelists, one of whom used to practice as a public defender, primarily in problem-solving courts, discuss that while problem-solving courts are really great, one of the limitations is that when we recognize that addiction is in fact a health problem, we nonetheless are constrained by legal resources and by the abilities of the legal system to have to choose who has the most potential to recover from an addiction and who has to be treated, or who we decide still should be treated criminally. And I wonder if you have any remarks on either how that could be solved, if it's a problem, how you view that limitation of how you select who can receive treatment and who might have limitations at the time that they're in your court that keep them out.
Yeah, that's, I think the problem with the state courts is that they don't have access to health care or health knowledge. And that's one thing that this group out of the Lansing area, Michigan State Medical Society, are trying to make a bridge between the medical community and the judiciary, because a judge is only as good as the information they've been provided. And so that's why we have rules of evidence and all that stuff. And so if you're sitting there and looking at someone who's faced with, drunk driving third offense or some other silly behavior, you want to know why and what's the best way to get them there. And for our treatment program, we evaluate either through social services or through the criminal justice. If the people are having a problem with an abuse and neglect petition, they're generally invited into the program. And so are most substance misuse, including alcohol cases, are invited into the program. And we try to work with them the best we can. But, it's not getting a diversion or anything like that. Their focus has to be on just getting better. And so, but I think the limitations in the state court are access to valid medical and nursing evaluations of the clients in the courtroom. I don't know how the state judges do it. Because I think it's a crap shot. And when you're dealing with someone, and I'm not a trained professional, but I know where to go find them and I know what to ask them.
Yeah, and there's not that connection or training in a lot of our state courts right now.
No. And so you have the stigma and that it's going to take time. And like I said previously, for the law students, get involved, run for office, get in the courtroom, raise hell. So if this means that much to you, do something about it, because you're going to have a license to do that.
Mm-hmm. We have a comment, which I think is good in the Q&A that relates this topic to current events. The commenter says, while the need for public health is now considered part of the solution, the problem is a lack of public health services, which has been brought to the front and center during COVID. In some states, like the one I live in, Missouri, public health resources barely exist, which is a huge problem, especially for the meth capital of the nation. Missouri presents many problems with this. It is not a Medicaid-friendly state, and legislators are constantly passing laws that put up more and more barriers to meet these needs. And I think that is maybe something that could be commented on with the idea of a unified social service like the benefits depot. How does the fact that our current systems are so fractured, defunded, privatized, and often subject to political action by state legislatures, how does that affect an idea like that?
So this is Robin. That's a great question, Robin. One thing that we haven't talked about yet is the degree to which we have a federal system, meaning one in which the states can make their own individual judgments about specific things, not least of which is what you talk about, Medicaid and Medicaid access, to services. That's a large debate in this country. I mean, I personally think sometimes that the level of government where we can be most responsive is at the lowest level. And, I'm a big fan of state lawmakers in particular and trying to get them to be more responsive to people, to see the humanity of it. I actually think there's a lot of work to be done in this area in helping bring data to bear on policy choices and to help lawmakers see a return on investment in the humanity of people. We have made such a massive investment during COVID in human capital. Okay, now it hasn't been well distributed, as Courtney said, so the people who might have the greatest need got the exact same amount as money as these other people. And I'm not saying that we've done this particularly well. And COVID has been in some ways an important eye-opening experience for many people to understand disproportionate impact, that people came to this crisis vulnerable and some people came more vulnerable than others. So I think you know, one way without trying to disrupt the whole federalization, you know, federal versus state level provision is to do more work with policymakers, helping them understand how the upstream investments pay dividends. Okay. We have a particular challenge in Illinois, unlike some states where the judge said, I think Michigan's way ahead of us. Maine, interestingly, is at the vanguard, California. But we don't look at experiences of a single person or user of government services across their lives particularly well in Illinois because of barriers to sharing data between agencies. Lawmakers have told us this. But if we could, it would be so important and profound, I think, because if you spend money, Judge talked about reunification, okay? When you take a child out of a home, sometimes it needs to happen, but when you do, it becomes a one-way street to foster care, and the chances of reunification are very small. And those placements are wildly expensive to the fisc, but wildly expensive to that child who might well age out of the system. And if that child then finds themselves homeless because there isn't a whole lot of provision for those children aging out, they may be substance users, they may get criminally involved. And that is wildly expensive to all of us. So, you know, there's if we could trace through these investments, I think we could show a return on investment in treating people more humanely. And that's one of the larger emphases of the medicalization of poverty work that I put into the chat. So Robin, you kind of you asked in some sense the hardest question. But we have to do a better job with our own representatives explaining the connections, and we need to bust open the ability to see those connections through better data. That's a meta problem in this country.
Well, I'll tell you, it just, if you're in Michigan, and Wayne State is, to look what's going on in Lansing. You've got a Republican charged legislature, both representatives and Senate, and they just voted yesterday, the Senate did, to allow this, the Senate leader to sue the governor. And what's going on is that you had this inflow of federal money from COVID money, and Governor Whitmer had taken the position of trying to a year ago and trying to deal with a COVID problem, and the legislature was not happy. She happens to be a Democrat, and the leadership was they're all Republicans. And now we have this fight over federal money coming into the schools and whatnot, and it's about power and authority. And so when I say, you know, you're going to have law degrees, use them. Either in policy making, run for office, run for a state rep or Senate, or support those people who know the difference between epidemiology and something else. I mean, last week they spent time arguing about opening up a season for cranes, sandhill cranes. They want to start shooting sandhill cranes. It's out of whack. I mean, we've had 15,000 people die in the state of Michigan, several thousand come down with COVID, and this is what we get. The Senate votes to allow Shirkey to sue the governor over her authority to deal with the COVID. I mean, this is ridiculous. You can't make this stuff up. Public health has been relegated to the lowest on the as the most on important issues in state government. It just has, it's all falling upon the 83 different counties, and they have enough money to do perk tests for sanitation. It's got to be elevated. And in fact, you know, even the previous administration creating the Department of Health and Human Services, they've created a Leviathan. It used to be a Department of Community Health. They created a Leviathan thinking that it would save lives and save money and do that. It's done just the opposite, because you're dealing with water quality on one end and child protection on the other. So Michigan's got some real problems, as far as I'm concerned, in the rolling out of public health and dealing with the COVID or any other kind of infectious disease. You know, we forget that there's Hep A, Hep C, HIV. the flu, a number of other infectious diseases, and that could take us out. I mean, in my court, most of my people who rely on injections have Hep C, and we deal with that as a court and get them treated. But at the state level, it is an absolute mess. I don't care if you're Republican or Democrat. It's an absolute mess. But anyway, that's my 2 cents, and I'll get off the political box.
Well, thank you for the 2 cents. We are just about at our time limit, so I would like to thank all of our panelists and everyone that asked questions, and also to just everyone who joined us throughout the symposium, the journal members, the law school, the Levin Center, my fellow board members, especially Ben Van Bar. And it is 1:30, so I will let everyone go, but thank you so much.